Welcome to Airway Answers, expanding your breadth of knowledge. My name is Nicole Goldfarb, and I'm a speech-language pathologist and certified orofacial myologist. And I'm here to help you find your airway answers. We're in this together. Let's do this. Clapping and cheers for Dr. Mike DeLuke. Thank you so much for being here, Dr. DeLuke. I really appreciate it.
Oh, my pleasure. Thanks so much for having me, Nicole.
So I assume most people know who you are. Dr. Mike DeLuke is a superstar. So you've started the Doc podcast a little bit over a year ago, right?
Yeah.
Yeah. And it's just taken off. And I feel like your name is everywhere. And
thanks.
I was on your podcast a long time ago.
Yes, thank you. It was a great episode.
We had such a great conversation. And I feel like we are going to really need to pay attention for time because you and I, I'm sure, are going to talk because we have so much to talk about.
If you want to do another one down the road, we can. I'm happy to.
We will. We're going to have to. So let me introduce Dr. DeLuke. It's so wonderful to have an orthodontist on the podcast, an airway focused, airway educated, airway understanding orthodontist. So we're going to talk all about airway orthodontics and different techniques and mindsets today. So Dr. Mike DeLuke obtained his DDS from, I'm not sure how to say this, SUNY Stony Brook, is that how you say it?
You got it. Yep, SUNY Stony Brook.
Yep. Stony Brook, where he graduated as class valedictorian, of course, and was inducted into Omicron Kappa Upsilon. He obtained his certificate of proficiency in orthodontics and Master of Dental Science degree from the University of Connecticut, serving as chief resident in his final year. Dr. DeLuke is a diplomat of the American Board of Orthodontics, served as an orthodontist on the prestigious cleft craniofacial team at Albany Medical Center, which is awesome because as a speech pathologist, that is a population that we work a lot with, our cleft and craniofacial anomalies. So that's really great to have you have that special training. And also served as clinical professor at both Ellis Hospital and the University of Connecticut Health Center Department of Orthodontics, and is currently an adjunct professor at the NSU College of Dental Medicine in the Department of Orthodontics. Dr. DeLuke owned and operated DeLuke Orthodontics in upstate New York from 2005 to 2023. And he launched DeLuke Orthodontic Coaching in 2022. So we definitely want to talk about that as well, because your role is to help educate orthodontic residents and other orthodontists in this airway realm, which is so crucial. Dr. DeLuke's mission was to help his colleagues succeed both personally and professionally. Dr. DeLuke has lectured at numerous regional and national meetings over the past 20 years, has published articles in multiple orthodontic journals, and sits on the editorial board of OrthoTown magazine, and is also the creator and host of the Doc podcast, which is one of my favorite podcasts as I'm running. I listen to. I was getting special the other day.
Thanks. Yeah.
So everybody's got to listen to your podcast as well, because you have really great topics. And I feel like you and I are on really much the same page, where you come from the orthodontic perspective. I come from the muscular soft tissue perspective, and we're all airway, putting it all together. So thank you again for being here.
Well, thank you so much, and for that kind introduction as well. And it's my pleasure. And thank you for all you're doing in this arena. Really, it's a movement. It's a movement. And it's funny how a bunch of us have just met each other. I mean, we become fast friends. I mean, 6 months ago, we didn't really know each other. I'd heard of you. I knew who you were, but now we've been able to correspond and communicate and realize, as you said, just how much we have in common for this common cause.
It's like we all have this underlying connection, and it's like, oh, these are my people,
Yes,
and probably
exactly.
most of the people listening, those are our people, this airway family. And so I want to ask you, how did you become interested in the field of orthodontics to begin with? And then how did you kind of shift from maybe a traditional orthodontic perspective of focusing on teeth to an airway minded focus?
So I come from a family of dentists. My dad, his three brothers, their father, all were dentists, my grandfather, and two were my grandfather and one uncle were oral surgeons, and then the other three were general practitioners. And then actually, I was the first of the third generation to become a dentist. And since two of my first cousins, my one uncle's children, have both become, one's an endodontist and one's an oral surgery residency. So it's a family affair. And so I knew I was one of those, I knew from an early age. My family was actually great that way. It was never force upon me, never said you have to go into dentistry. I just saw the way they practiced, the respect they had in the community, and the value that they provided, their services provided to our community. And I admired that. And I had a really good experience overall in my orthodontic care. And so I started thinking, literally in like 8th grade, geez, maybe I want to be an orthodontist. And then went to dental school and started thinking, well, maybe I want to do surgery. And at that time in the 90s, implants, placing your own and restoring your own implants was kind of becoming a big thing. And so I was like, maybe I want to go into that. And then I did a little bit of a viewing externship at a faculty member's ortho practice and fell in love with it. And by 3rd year of dental school, I just realized, no, this is my calling. I love the kiddos and just the lightheartedness of ortho. And I really enjoyed the ability to connect the science and the art, which I feel orthodontics has a really unique ability to do. And so that led me down that path. And so I went to UConn, which is a really well-known orthodontic program. I was trained by kind of the founder of biomechanics, Charlie Burstone. He was still alive and taught me biomechanics. And he is literally, anyone who knows orthodontia knows of Dr. Burstone. And so it was a traditional program in that sense. We learned to be amazing tooth straighteners, just as sadly is still happening today. This is early 2000s, so we're over 20 years ago. But we really focused on being really good at moving teeth. And we can get into today, if you want, some of the reasons for that, because I do have some thoughts on why that's the case, especially because I've been involved in academia as a professor and on the faculty side my whole career. But that being said, I mean, we learn about the growth and development. We learn about, obviously, craniofacial development. We don't really spend a lot of time connecting the fact that we can do something about that in the way that I then, when I became a practitioner, realized I could. So I got out and I started my own practice day one, literally hung a shingle. I finished my residency at the end of June, and July 5th, that the practice started. DeLuke Orthodontics opened and I had no patients. I did, interestingly, during my 3 years of my residency, I did some moonlighting at my family's practice as doing general dentistry, which was amazing experience for me. Really helped me gain my confidence that I could practice on my own and do this on my own. And so I started my practice up and just built it from nothing. And, Nicole, I realized early on as I'm looking at these patients, something was different, because in your residency, you might see a 7-year-old or 8-year-old. And I say might because you don't see many of them. Some residents don't see any that age, believe it or not, or younger. I mean, you don't see kids till they get to be older, sadly, in a lot of residencies. And so I'm looking, and these patients that are coming in to see me for their first exams are 6, 7 years old. And I'm thinking, I didn't really learn what to do with a 6 or 7-year-old kid. Like, I mean, I don't really know what to do. All we did was, if there's a crossbite, obviously fix that. But if there's not a crossbite, we were taught you don't treat the patient. You don't expand a patient in the absence of a crossbite. And so I'm looking, but these patients have moderate to severe crowding. They have narrow arches. They have no tongue space. They weren't growing well. And I'm looking at them and the parents, and I'm thinking, in residency, we were taught, well, you got to go get, say, the primary canines out and start them down a serial extraction pattern. And I just started to look at this and say, that's not treating the cause. That's treating the symptom. Because, and McNamara's got a great study on this in the early 80s, 83, that he did with O'Connor and Howe, where he looked at 104 dental casts, and 50 of them had severe crowding, 54 didn't. And they measured the teeth sizes on these casts, and the teeth sizes were almost identical. Yet some patients had severe crowding and some had none. And so they concluded that dental crowding is conclusively a arch width problem, not a tooth size problem. And there's been other studies. Mills actually had a study on that back in, I think it was the 60s on that. I mean, this has been known for a while that when we look at crowding, it's rare that it's macrodontia or that it's a bunch of big teeth. It happens, but that's really the exception. Almost always it is narrow arches. So I'm looking at this, and I was at that point, I had time because I was building my practice. I didn't have a busy practice yet. So I was still going back to UConn to teach a couple of days a month. And this was well before PubMed and everything was so prominent and you could get articles online. So I would go to the library at UConn early or stay late, and I would just start pulling articles on early expansion and expanding mandibular arches and things we just didn't learn about at all in residency. And I started to realize like Schwartz, Gratzinger, they were doing this in the 60s. I mean, this has been done, expanding the mandibular arch and going in proactively and going back to Bogue. I mean, in the early 19 teens, right? And they were treating patients in the primary dentition. So I started learning about this and thinking, okay, so there is a precedent for treating these kids younger. You don't just have to relegate them to needing 4 on the floor, 4 buys out, and leaving the transverse deficiency. No concept of Airway yet. Like not even, no idea, not even any clue that anything I was doing had anything to do with Airway. And so I just was looking at treating the cause, not the symptom. And so I started with these patients, literally asking them, well, if you want, I can kind of try this. It's not gonna hurt anything, but it might prevent us from having to take teeth out. Again, in my mind, it was still all about the teeth, right? I was just literally thinking, maybe I can fit the teeth in. And so at that point, within the previous 10 years, a lot of studies had come out in my field saying there's no need for phase 1 treatment. And we can talk more about this, but that phase 1 has no benefit. And I can certainly cite those articles and go on into why they're very flawed. But there was a big push away from phase 1 at that point. And so I was thinking, well, we're saying it doesn't really matter to use phase 1, but I'm going to try this. I'll be upfront with the parents and we'll just try to develop these arches. So I tried different modalities and ways of doing it. And literally just kind of figuring it out, how to develop these arches. And lo and behold, as I started doing this, I noticed the arches started taking normal shape. The tongue had space, the teeth had space. Everything just looked and fit better. Now I was using turnkey expanders and my designs were not the best at that point because I was still figuring it out. So I still had a lot of heavy lifting to do in phase 2, a lot of times, but still I was almost never having to take teeth out, except sometimes impacted canines would cause that to happen, have to take upper buys out, but it was rare, but that was more of a technique issue. But I was just starting to figure out, like, I can do this differently. Fast forward maybe 4 or 5 years into that, and I start realizing I'm getting asked a lot by parents, hey, Dr. Mike, do you think the fact that like she doesn't snore anymore has anything to do with these expanders? Or do you think the fact that like they sleep better and they sleep more soundly has anything to do with these expanders? And embarrassingly, Nicole, I'm like, oh, maybe, I don't know. Like, it could. I mean, I'm not going to say it's not, but I don't look at the literature a little more, and there's nothing super conclusive about that. And I said, we know expanders can increase the nasal volume and capacity as well. So maybe that's related. And it wasn't until then I got a cone beam. I was an early adopter of CBCT technology, and I got a load. I didn't love the higher radiation, and so I waited. And thankfully, they had a low dose machine that came out, and I got it in 2014. And that's when I started to put it all together. And that's when I started to realize that I'm looking at these patients now in 3 dimensions: their nasal passageways, their pharyngeal airways, their tongue space, in coronal slices, getting to really see these patients, height of the palate, all these things we just can't see in our standard 2D pan and Ceph imaging before and after treatment. And I'm seeing transformational changes in these patients. And now I'm understanding when I see certain hypertrophy of the nasal turbinates or of the lymphoid tissue, developing relationships with my allergy and otolaryngological colleagues to refer these patients, and starting to develop a more patient-centered, comprehensive patient wellness approach that I literally just kind of was stumbling on because as I advise all the residents I teach to do, I was studying my before and my afters. When I finished a case, I would always study the final and look at it and compare it to the initial. And that's when I started to put the pieces of the puzzle together. And then from there, we can talk more about kind of how that expanded into a much bigger Airway journey. But that's really how it all developed.
That's so amazing. So your curiosity is so important for us to not just take the knowledge we're given and just follow a cookbook, but to actually think outside of the box and be curious and think about the why. That's what gets us to a new level, right? You were curious. You took the energy and the effort on your own to go to the library, to research, and to think what's really going on here. And it's also interesting that you are still thinking from a tooth perspective, and that Airway is that plus, that additional like secret sort of icing on the cake. And I think it's also fascinating. You got the CBCT, and then you were able to see deeper. So really what we're seeing on the outside is symptoms, right? Crowded teeth the behavioral issues, those are symptoms, but when you can actually look deeper and look into what physically is wrong within, you can really see airway. They're not breathing well. The carotid teeth are a reflection of poor breathing
Got
and
it.
behavioral issues. And it's like, wow, I just love how that all came together for you. And
Mm.
now you're taking your knowledge to help spread this message and educate other people because it's so important. I want to ask, like, what is the difference between a traditional orthodontist and I know there's not a field of airway orthodontics. It's not like a profession,
Right.
but I kind of like to call like airway focused dentist or airway focused orthodontist. I don't know what you would call that perspective, but what's the difference between those two and what wording would you use?
It's a really interesting question because we debate over that, and I'm a believer that what we call things, wording is important, and the terms we use to describe things is important. And so I know there's a big push against the use of, say, airway orthodontics or airway dentistry, and I get that because that puts the airway first. And I think sometimes when people focus too much on airway, a lot of the people I coach and help, I tell them just because so easy when you're a hammer, everything looks like a nail. And once you start going on this airway journey, you start thinking every patient has an airway problem, and they don't. They don't. Your job is to figure out who does and who doesn't, and then based on that, determine what you do. And I actually say, I'm opposed to both extremes. The people who say airway's not involved ever, and the people who say airway's always involved in every single patient. I don't like those extremes. Because I feel like it's a bit of a cop-out to just kind of apply a standard formula to make your life maybe a little easier as a practitioner, to be honest. The time in the diagnostics and looking at the signs and symptoms at the Winds of Change meeting coming up, which you'll be speaking at as well. I'll be talking about that. I'll talk a lot about the how we start to look at this because no one teaches us. No one in our residencies, in dental school. There's very little CE on it as well. How to recognize the signs and symptoms of an airway problem in pediatric patients, especially, specifically speaking of the children. So we don't really know what we're looking for. And so I think sometimes it becomes easy to just say, nope, it's never a thing because I don't know what I'm looking for or what to do about it. Or it's always a thing because I'm just always going to throw this same thing at it and hope, that it works most of the time. And I'm not causing any harm if it's not an airway issue. And I don't like either of those approaches. I like teaching, and I teach my residents. I teach when I coach and present how to look at these patients from a general health perspective, from the outside in, looking at the faces, looking at the growth and development, understanding why a patient presents with the malocclusion they present with. And when you start to do that, and then you develop the knowledge to understand the nasal anatomy and the pharyngeal anatomy and the space that you should have for air to flow and the whole point of nasal breathing and why mouth breathing is a detriment. And once you understand all of those things, then you can start to look at your patients. And then the next level is understanding and being able to get the information from your patients or their parents in this case, if they are snoring or mouth breathing or having ADHD type symptoms or behavioral issues, because we now know of all the neurocognitive issues that go along with sleep related breathing problems. So to me, and a long answer to your question, but to summarize it, it's the orthodontist who focuses on airway and the orthodontist who doesn't focus on airway, or the dentist who doesn't. They're trained essentially the same, right? Same degree, no difference per se. I feel it's a difference in philosophy and how they approach their patient care. And the one thing I'll add to that is a lot of orthodontists are guilty of, and I get it, I have been there running a very busy practice. And when I made a lot of these changes, Nicole, it was not easy because when you're seeing 75 patients a day and you're running right on time and everything is working like clockwork, you start to incorporate some of this additional diagnosis time, some of these additional behavioral modification techniques you have to do when you treat patients who are a little younger or maybe having some more issues on the special needs spectrum or side of things. It takes more time out of your day. And I hate to say it this way, but it's a fact. And people who know me know I'm a straight shooter on this stuff. I say it as I feel it is. And I don't say it to insult anyone. I just say it to be honest. It's a lot easier to just put your head down and keep straightening teeth. It really is. And so that's one of the main reasons I feel, we don't get taught this in school. We don't learn this. And then, so you not only have to pursue this additional journey of all this education and knowledge, and then you have to overcome all the dogmatism and everything you've been trained on. And now you have to uproot your systems and your practice to implement all these new techniques and technologies and approaches. You can see why a lot of people don't want to go on that journey.
Yeah. If you're comfortable and you are not curious, you have to be curious. You
Yeah.
have to be curious like you were, and you have to care. And
Have
if
to
we're
care.
kind of set in our routine,
Yep.
we might not really care. So that's a good way to understand. And maybe a traditional orthodontist might are really focused on straightening the teeth, right? And the occlusion, and not looking so much beyond the teeth. Is that
Correct.
maybe okay? And when we talk about looking beyond the teeth, we're thinking of jaw size, palate width, beyond just how the teeth look lined up and pretty and straight, but breathing, nasal breathing, allergies, issues, all the way to like GI issues,
Yep.
reflux, like thinking like whole body and how breathing relates to the cranial facial respiratory complex, right?
Right.
Or
Right.
dental complex, maybe versus
Right.
cranial facial respiratory.
Right. Right. And a proactive approach, meaning instead of, I feel like orthodontics by nature is a very reactive profession still, right?
Mhm,
I mean, we're looking at trying to fix a problem that's already there.
mhm.
And we are abandoning the fact that we can go in younger and try to prevent some of these problems from occurring. And we literally fight and we try to do research and put out articles to prove that we can't do anything about this, that all we can do is just let it happen and just try to fix it when it's broken. It literally boggles my mind that that's what we're doing to ourselves, and that's what our establishment does. But that's the reality.
Wow. So if you could explain what is phase one and
Mhm.
phase two orthodontics? Why might that be controversial? And what age does phase one start? And what does that mean? And then I'm going to add one thing to that, because I've experienced with my kids phase one, phase two. I mean, and
Mhm.
now I think we've done more. I thought we were done. And it's like, no, we have to continue as the face grows. Think more things need to occur. So does it ever go beyond phase two?
So it's again talking about nomenclature and what we refer to things as being important. I feel like there has to be a shift in how we talk about all of this. The traditional nomenclature for the way we term phase one. There's people out there who advocate for phase none, right? People who are against any proactive treatment are called phase none. Phase two, which is if you've had a phase one. Comprehensive treatment, which would be if you're like an adolescent who never needed a phase one, and not everybody does need a phase one. So like if you just came into my office and, or let's say even came at 8 years old, 7 years old, and you were fine, you're growing well, maybe the bite's a little deep, maybe a little bit class 2-ish, but no airway problems, no functional issues, no significant attrition of the teeth, no parafunctional habits. That patient does not need to be treated, right? Just because they have a malocclusion at that age, that there's really no benefit. If you know what you're doing orthodontically, you can fix that. And sometimes it is just the teeth at that point, right? Like it's just, they just have the teeth. They're growing normally. Their transverse is good. I'm not of the philosophy that you over expand someone past the biologic parameters and past the normal amount that they should physiologically be to just try to treat an airway problem, right? That goes kind of down a different path, but I'm big on normalizing the anatomy. When I had Jeff Rouse on my show, he and I were talking a lot about that, and I borrowing that from him. And I told him I was going to steal that because I love calling it that. We're normalizing anatomy. So the difference in phases, from my perspective, is, does that anatomy need to be normalized now? Or is that anatomy within a realm of malocclusion or issue where if you don't jump in, or if the craniofacial growth is aberrant to a certain extent, can you make a difference in that? That will have an impact on this patient that will benefit them greater than doing nothing and just trying to straighten their teeth when they're older. So if you look at a patient younger, there's no airway problem. They, mild malocclusion, maybe a little extra spacing, a little extra crowding, no psychosocial issues from it. Kids thriving, no problems. Just because they have a little deep bite or because they're a little class 2, show me the evidence that we need to do anything for that, right? Because I can fix that when they're older. Take that same patient and give them narrow arches. Maybe they're a little more retrognathic. Maybe they're growing a little more vertically, right? Same age patient, excuse me. And you have all these other problems. Now they have a little more crowding. Well, now I'm starting to figure out, well, why is this the case? Well, sometimes airway plays a role. Sometimes it doesn't. It's my job to figure that out. But I still want to normalize their anatomy because there's other issues that are a level of severity that are enough that I know if I let this go and I don't do anything about this, I'm either going to have to get really lucky and hope they, as we say in orthodontics, are a good grower, is a term we use for this, or I'm going to have have a lot of heavy lifting to do in a few years if I don't do anything now. And so those patients, and this is a really nuanced point, but it's important. Teaching people what to treat and what not to treat is one of the biggest challenges I face, because as I said, once you start learning this, you want to just treat everybody with everything that comes in. And that gives the whole movement of understanding airway and treating patients with a more proactive approach a bad name, because then people say it's just greed. It's just, you're overdoing it on the other side. So it's something that I teach. And what I say is, and in full disclosure, in my practice, I never treated a kid under 5, maybe 5 to 6 was the youngest, but I just didn't. I didn't have kids sent to me that age. I didn't understand it. I wasn't even on my radar to be doing that. But I was an outlier in my community and in my profession just for going in at 6, 7 and trying to help these kids grow. So I have no problem. And I've seen great examples of where going in younger can be beneficial and can be very, very helpful when you have the other issues. Again, it's not that every 3, 4, 5-year-old needs orthodontic treatment, but there are some associated airway issues, myofunctional issues, oral musculature issues, tongue tone issues, all of these things, tongue ties, all of these things that can be part of it that we need to be taught to recognize. So that patient, yes, we can go in and do some proactive treatment on that patient, because if we don't, we can be certain that there are going to be comorbidities that are going to develop, and their craniofacial growth and development is going to be altered, and their neurocognitive development is going to be altered, and there are all these other sequelae that happen. So yes, we can. That being said, we go to the next kind of jump, which is when they're getting, that's in their primate dentition. Now they're getting their permanent teeth starting to come in, their incisors, their 6-year-old molars. And that's kind of the traditional phase 1. So part of the reason there's no real name for treating kids younger than that. So that's the traditional sort of phase 1. Well, traditionally phase 1 is literally you get rid of a crossbite, or you'd maybe throw a headgear at a class 2 patient. Even though they're retrognathic, you would give them a headgear to pull the maxilla back. That retractive concept was what is still done by a lot of people. Even though we know from, again, McNamara study in the early 80s, it's rarely ever is a class 2 due to a prognathic maxilla, but we still go after the maxilla incorrectly a lot of times. But traditional orthodontics, speaking from that standpoint, those are the things we'd go after in that phase 1. Crossbite, unilateral or bilateral, or anterior, and maybe a real severe overjet type of situation. Some people would go after severe crowding. They would put things like lip bumpers in, and they would try to put like a holding arch up top to try to preserve the arch length. Again, ignoring the arch width, that's a whole nother discussion, but trying to preserve arch length. So that's like your traditional orthodontic phase 1. Now, we talked a little bit about earlier, and you referenced in your question, why do a lot of people not agree with the need for a phase 1? Well, a big part of that, Nicole, is that a lot of people don't do it correctly, so they don't think it works. If you look at the studies, 𝐃𝐈𝐒𝐂𝐋𝐀 and Schiffman had one in the early 90s, and then Gianelli had some throughout the 90s and early 2000s. And then there was one, 𝐃𝐈𝐒𝐿𝐿, 𝐃𝐈𝐒𝐿. He is a thought leader in our profession. Taught a residency, I believe, Temple for many years. I think he just retired. And again, this is not a personal criticism of any of these people. I'm strictly speaking objectively on the work they published. Nothing personal on any of them. They're all brilliant individuals and have done a lot for their profession. That being said, the messages they put out, 𝐃𝐈𝐒𝐿, he published a study in the AJODO, which is our leading journal, in 1993, which referred to orthodontists who are believers in the benefits of phase 1 as quacks and charlatans. That intimidates people, right? This is our leading journal. And they think, well, geez, maybe there's something to this. He says, then actually Gianelli was talking about the fact that everything was about fitting the teeth in. And it didn't matter if you did a phase 1, because there are ways to fit the teeth. And I think he says in 85% of patients, you can fit their teeth if you wait until they're like 10, 11 to start. But again, the argument was all about fitting in the teeth with these people. It was purely tooth driven. 𝐃𝐈𝐒𝐿 and Schiffman had an article in 2001 after that. And they they're looking at ways of performing phase 1 that aren't standardized. So the initial presenting malocclusion isn't always standard. The treatment performed isn't standardized. The amount of expansion, or if you expand it, none of them got lower expansion. They all basically were just upper expansion, which again is a whole nother issue on why that doesn't work effectively often if you're just expanding an upper without a posterior crossbite. And it was headgear, some had lip bumpers, and then there's no standardization and retention protocols. So I say all the time, I mean, you can take any type of orthodontics, and if you don't know what you're doing and don't do it well, you could say orthodontics never works. Like if you don't perform it well, I'm sure it's the same in your field. If you don't, you could look at someone who's maybe trained as an oral myofunctional therapist, but if they're using modalities or using techniques that are not effective, you're going to conclude that myofunctional therapy doesn't work. And that's what these studies are. And there's O'Brien had one in, I think, 2006. I mean, there's lots of them out there. And the sad part is they're very poorly done. And they then use these, the establishment of our profession uses these as reasons why phase one has no value. They don't mention, not one mentions Airway. Not one mentions their overall. I mean, people don't even know about the behavioral and cognitive issues associated with the way we breathe. I mean, the orthodontic community doesn't have any idea en masse about this. Obviously some do, but the general greater population, academia, they're not teaching this. So that's why that phase one has become such a controversial topic of whether you do it or not. And then phase two would be, if you do phase one, then some of those patients will need a second phase. And we told every patient, expect that you need it. If you don't, it's a bonus. Interestingly, when I was using turnkey expanders, I saw more patients than not, probably 90% needed a second phase. When I went to doing it with braces and wires and developing the arches that way, I had many, many patients that didn't end up needing a second phase. I got such a better result, which again lends credence to the point that the better you do in that first phase, the less work you have to do later because you've normalized the anatomy to a greater extent. So there's less heavy lifting later. And then some patients are just, they're super retrognathic. You're not going to grow a mandible extensively in a 7-8-year-old kid. You just, biologically, that's rarely ever going to happen and be stable. So kids full cusp class 2, narrow arches, high vaulted palate, crowding, you go in, you develop the transverse, you try to get a little bit of that retrognathia addressed if you can in phase one, and you tell the parents they are going to need more definitive AP correction of their retrognathic mandible when they are closer to peak skeletal maturity, and we're going to go in and address it at that time. So it's just, again, normalizing anatomy. And when you know the craniofacial growth and development, which I contend orthodontists do better than just about anybody out there in the medical and dental professions, this isn't hard. It's just, we are so dogmatic and we are so trained that this isn't the case and that it can work. And the last thing I'll say about that is, I think a lot of it, we talked about the fear, we talked about the dogmatism, a lot of it, I hate to say this, and Claudia Pinto was on my show recently, and she said, we have to be very careful not to let the treatment follow the reimbursement.
That's what I was saying.
And I love it because a lot of these patients, if you're a par provider, I had the advantage. I had a few advantages. I started my own practice. So I started with no patients. So I had the time to be curious. I had the time to figure this stuff out. If I wanted to change something, I was my boss. I could do whatever I wanted. A lot of people go in and practice with someone else and they have to do it the way they did it, or they go into a thriving practice and buy out the doctor. And then they're just trying to keep their head above water to keep things moving that way. And I get it. So I had an advantage that I had that time. I also had an advantage that I never was a participating provider with an insurance company. So I could charge what I wanted, when I wanted, how I wanted. Obviously I was sensitive to people who had insurance and we wanted to work with their insurance. That being said, I didn't have a company. I didn't have Blue Cross Blue Shield telling me you can't do phase one because we don't cover it. And anybody who says that's not a factor is not being truthful. It is a factor. Actually, that article I referenced by Orthodontics in some of the Gianelli articles, they reference that you burn up their ortho insurance benefit if you do a phase one. I mean, they're literally saying this out loud. So the money is a factor in this. And I looked at it as my job is to do the best thing for my patient. And I tell the parents, not every kid needs two phases. You have a child who does. And that means we need to go in and normalize their anatomy now. And then when all the teeth come in, we should have a lot less work to do later than if we did nothing. And we should have a much better outcome long-term. And we're going to help other areas, their growth and development, et cetera, airway. Then we do the final alignment, which would be the phase 2 that you referenced, when they're older. And then the last part is when you do a really good phase 1, I was in no rush to do a phase 2 if they even needed it, because their teeth look amazing. Their smile looks amazing. They look good. They're confident. So they're not feeling like they're 13. Maybe they have delayed dentition development and they're 13, 14 and still don't have their 12-year-old molars and still have a bunch of primary teeth in there because they have slow teeth. Great. They're happy with their smile. They look great. They're confident. There's no rush to jump in there. And that keeps you, when you do a good phase 1, it keeps your phase 2 really short, because I waited essentially until all the adult teeth had come in, or skeletally, if we needed to jump in on a retrognathic patient, we had to do that at a certain skeletal age. But dentally, if it was just a matter of some teeth erupting, a little bit rotated or crowded, just wait it out. And then if they want Invisalign or whatever aligners you use, or some quick braces when they're adolescent age, great, go in and fix it. And that's the difference of the different approaches. I know there's a long answer for that, but it's a complicated concept that's so often misunderstood.
Yeah, and that's really great to be so detailed, because it is confusing and there's different philosophies. And that's interesting to note that don't let the treatment follow the reimbursement. And in the United States, phase 1 is not covered in many cases. Is that correct? Through insurance.
Right. If you're a participating provider, they won't cover a lot. I mean, if they're going to cover a phase 1, it's a really low reimbursement. And if you're not a participating provider, like our patients, if they had an insurance benefit, they still got that benefit. If they, like I said, a $2,000 insurance benefit, but it's typically a lifetime benefit for that patient. Yeah. So if you do it in phase 1, they're going to use their whole benefit, and then there's no benefit left for the second phase. Interestingly, Nicole, to that point, I've heard many people say of my colleagues over the years, going back to my residency, say, don't get the teeth too straight in phase 1, because then they won't want to do a phase 2. And these are some of the same people who hate on phase 1 and Airway, et cetera. So where are their motives, right? What is their true intention? Are they really about doing what's best for this patient? And then they'll be critical, saying, well, you're just doing 2 phases to charge more money. It's like, I'm doing 2 phases because it's what's best for the patient. And on the cost of it, my treatment coordinators, we would always tell patient families up front, 2 phases typically costs about 35 to 40% more than 1 phase alone. So if you just came in with your 13-year-old and they just needed braces, routine orthodontic treatment, it'd be X fee, right? If that patient, a different patient, your other child comes in at 7, needs treatment, and then needs second phase as an adolescent, that's typically going to be about 35 to 40% more money. It's not double, it's about 35 to 40% more. So, I mean, that's an industry standard. That's pretty standard across most practices. So we're different. All our bodies are different. Some people need multiple phases, right? I mean, it's just to me, I think it's gotten really off track by a lot of misinformation.
And I think most parents would accept that if they understood this from a health perspective versus you're lining up my teeth for a pretty smile perspective.
Completely agree.
And when we say, well, potentially phase 1 might not be needed, and we can just do orthodontics later when the child's older, like 10, 11, 12, 13, whenever, the orthodontist must be asking the right questions. And are they asking the right questions at that point when phase 1 could be initiated? And I'm talking health airway questions.
Yes.
I think you can't clear out that child does not need early intervention or quote unquote phase 1 if you have not asked the appropriate questions. If you're just viewing it as tooth alignment, and saying, no, we'll treat this later, then you've just missed a huge opportunity to change a child's life, right? And how many orthodontists are asking those questions?
Or doing the diagnostics, and doing the diagnostics. You're 100% right.
Yeah. So, and I mean, there's a huge correlation of comorbidity or high incidence of malocclusion and airway issues, right? They pretty much go hand in hand, although we can't say everyone with malocclusion has an airway problem, but there's a really high correlation between those two.
Completely. And I think you could almost say the converse of that, which is a large majority of the patients who have an airway problem have malocclusion. And so I prefer to take that approach to it, because my job is to figure out, when they come in with this malocclusion, do they also have an airway problem? Because of the fact that they are so intimately related. In the medical literature, I mean, Gimeno has been publishing on this for decades, and Shervin, I mean, we've known this isn't a secret that they're related. We know it affects craniofacial growth and development. We know now, again, from the Bonnick studies and the Gozal studies and the Isaiah study, that it is affecting neurocognitive development. I ask my colleagues all the time, what is your reason for not doing this? What is your reason for not wanting to do it? And a lot of them just say, because there's no research or no data to support that it does anything. And I'll throw research and data at them left and right. And they're just like, nope, AO white paper said we don't have to worry about this. And I'm like, did you read the white paper? Do you understand it? Do you know about the 2017 ADA position statement that came out? They don't think critically about it, Nicole. And I think a lot of it goes back to what we were talking about before, is it's just easier to put your head in the sand on this and not enact the change to do what you just said, which is take the time to recognize these issues and look more at the patient than just the teeth. And the other part about that is it's not easy to look back at your body of work and feel like you've done it wrong for all that time. And whether that means whether you're a faculty member or an administrator at a school, and you've been teaching residents for all these years that there's no such thing as an airway involvement in orthodontia, and we can't do anything about it. How are you going to get a direct program director who's been around for 30 years to change the way that they think? Truthfully, like, they would have to then go back and literally deal with having taught it incorrectly for all this time. How are you going to take an orthodontist who's been straightening teeth for 25 years, extracting a lot of teeth, treating the symptom, right? We can talk in a bit about whether extractions cause airway problems and my thoughts on that. But you've been not addressing airway. Let's just call it that, right? You've been leaving arches narrow. You've been solving it by trying to fit teeth together. How do you look back at 25 years of doing that and face the reality that you have left some patients in a pretty tough spot from a health perspective? Remember, we don't see our patients 20 years down the road. We have that unique advantage that we get to kind of wipe our hands free, like, hey, I've done my part. And a lot of the dentists I've had on my show have said to me, they just wish that orthodontists had to see their work 20 years down the road and see what's happened to these faces in these patients systemically, their health, the breathing issues they have, the functional issues they have, the TMD, the breakdown of the dentition, all the relapse of the orthodontia, all of these things. We get to just not look at that and ignore it and say, hey, when they left me, their teeth were straight. They didn't wear their retainers. And we kind of chalk it up to that. And I feel like that's a bit of a protective mechanism. And I'm not being critical, because I don't know what I would have done. Again, I had the advantage. I got to start doing it this way. And I did a lecture for Airway Health Solutions with Lauren, webinar a month or two ago. And I showed some cases. I had to go back. One was for my residency and one was for my first year of practice, when I did treat them not with an airway focused or a etiology focused approach, but treating the teeth, treating the symptoms. In these cases, I did extract teeth. And I showed the difference in 2 patients that were treated that way, and then 2 patients with similar presenting malocclusions that I treated with a proactive approach, developing the arches, helping them grow, cognizant of airway. And when you look at the results in the end, I mean, I got a pit in my stomach when I looked at what I did. These both were girls, that the way I left them, I felt bad about it. And that was 2 patients. I had to literally go looking to try to find a couple patients I treated that way. If you've treated thousands and thousands and thousands of people that way throughout your career, of course you're going to fight and say that there's no reason to do it differently. It's human nature.
And if you probably saw that future aftermath of some of those cases, if you weren't educated and interested and curious to believe, you would probably blame it on something else. Like, oh, she gained weight, so, she's that, or this, or, oh yeah, family has high blood pressure, so that's,
Right.
So you wouldn't relate that if you don't have that basic or base knowledge to know that relationship between craniofacial structure and airway, breathing, sleep, and health. You probably blame it on something else. So would it really help to look back unless you already were curious and interested? Couple things I remember from your interview with Jeff Rouse. He said he likes to treat or think of everything as an airway issue until proven otherwise.
Mm-hmm.
I like that thought. Like, prove to me that there's not an airway problem, but we want to treat with that airway minded focus. Why not grow the jaws forward, wide, expand, help that person breathe better, even if, we don't know if there's an airway problem yet. Let's get the best growth and development now that we can.
Right. Because we know that patients with obstructive sleep apnea later in life have narrow arches, higher vaulted palates, retrognathic jaws, have longer face heights, were vertical growers, steeper mandibular plane angles. We know all of this, ovoid facial forms. I mean, and people, I've debated this with colleagues, and they're like, oh, that's just, correlative. There's no causation there. Yeah, but when correlations are really, really strong and consistent, they are significant, and they are something we need to pay attention to. And I find it funny that people are willing to make the argument that we should leave these people with altered craniofacial anatomy because it doesn't make a difference in the end. But wait, it does make a difference. Maybe they are going to have a higher incidence of sleep apnea, but there's no causation there. If you're not doing the studies to prove the causation, which for many reasons is very, very difficult to conduct a study that would indicate that, at the very least, just do your job and normalize the anatomy. And that's what Jeff and I were saying. Like, do your job and normalize the anatomy. And I want to make it very clear. I never told a patient, I never teach anyone I coach or train to tell people you are treating the airway. I'm very clear about that.
Yes.
You are not diagnosing the airway, and you are not treating the airway. You are diagnosing the signs and symptoms of airway compromise, which we are more than capable of diagnosing, right? And then you are recommending certain treatments. Some of it is a referral to a medical colleague or a myofunctional therapist or whatever the case might be to help this patient normalize their anatomy. And some of it is, as the ADA says, perform evidence-based treatment to normalize the anatomy the way you do. And I've yet to find anybody who tells me that expanding is not evidence-based treatment in a patient who's narrow. Now, expanding in a patient who's not narrow with the hope that you're going to like blow everything out just to treat airway, now we can get into a little different discussion, right? Because now you could say, oh, I'm just treating and expanding just to treat airway. That does go outside of our scope of practice, right? Because now you're treating airway. Mm-hmm. Whereas if you stay in your lane and stick to the fact that you're normalizing the anatomy, why would you want to leave a patient with a high vaulted palate when they're younger? Like, why would you want to leave a patient retrognathic? Like, again, to me, I just don't understand the argument to not want to do something about it. It's like we fight so hard as a profession to prove that we just are just these great little tooth straighteners who just can do nothing more than just straighten teeth better than anybody else in the world. It's like, we're more than that.
Yeah. And it's the same with myofunctional therapy. So when I train people, I let them know these are the things you're treating. You're restoring normal oral function, correct oral rest posture, chewing and swallowing of foods, liquids, saliva. You're not treating sleep apnea. You're not treating snoring. Now, by restoring normal oral muscular function, those things tend to get better and nearly always do. But never tell the patient, I'm treating your sleep apnea, I'm treating your snoring, even though there's research showing there's a correlation when we get the tongue up, muscle strengthened, lips closed, nose breathing, those usually almost will get better. But once you say you're treating that, you're owning that. And that's not what we're doing, right?
No.
So we need to be really clear, because my goal is going to be, you are going to have your lips closed throughout the day, and when sleeping, your tongue will be resting in the correct position, gently suction to the palate. All those goals are all related to oral muscular functioning. My goal is not you're going to stop snoring, your sleep apnea is going to go down, because that's outside of my scope. But by restoring correct oral rest posture and functioning, that's like the icing on the cake, cherry on top, that usually gets better. So I like how that helps keep your focus in your lane, in your scope of practice, when you view it from that perspective and you word it that way. Couple things you mentioned. One thing you said about your treatment in phase 1, you might use braces and wires, and sometimes patients don't need phase 2. Now, I want to talk about that, because that can be confusing. When I think braces, I think retractive. Are usually braces retractive? And what is this braces and wires to expand? Because doesn't it just push everything back?
No. So actually quite the opposite. So I found that, because I started doing this, as I alluded to, with expanders. So I did thousands of cases with lower expander, turning slowly to develop an upright dentalveolar expansion, as many people know. I mean, as a little bit of an aside, if you tell them, I don't want to say the majority, but a high percentage of orthodontists out there, if you even say I expand the mandibular arch, they like fall over. They can't even comprehend it. And they're like, there's no suture, you can't expand. And I explain, I get it. The suture's fused. There's no suture. There's no patency in the suture. The suture's fused around birth. get it, but we're getting dental alveolar expansion. We're uprighting the teeth over the bone where they're supposed to be. And when you do that young and with the primary teeth, the permanent teeth will tend to follow. So I did it that way with turnkey type expanders, slowly on the bottom and rapidly on the top. Interestingly, in those patients, to your retraction stance, by not putting brackets on the anterior teeth, a lot of these patients, and it's one of the other signs you see in a lot of patients with sleep disordered breathing, they have retrusive incisors. So unless they have like a lip habit and they protrude the uppers, if they don't, then a lot of the incisors are retrusive, and which makes sense because they have more limited tongue space too. So when you just expand, you have very little control over those incisor proclination, right? When you use braces and wires, I designed the prescription for these cases to have, without getting too kind of geeking out on the technology side, but more torque in the brackets on the upper anterior teeth, which is going to take the upper incisors and procline them more because the dynamics of the interaction of the wire and the bracket will control that tooth movement. Interestingly too, there are studies out there. Rick had said some studies in the 70s, and people have shown that one of the biggest places you gain arch perimeter to get room for your teeth is actually by incisor proclination as well. So when you take these patients and you expand the width only, like with a traditional expansion approach, and don't address the anterior teeth, you're not getting as much arch perimeter, and you're not going to get the shape to the arch that you really want, that nice, beautiful ovoid shape, that kind of horseshoe shape. You still get more of a narrow V a lot of times.
Okay. Yes. So kind of like I think orthotropics philosophy where they flare out the upper incisors. So if you kind of tip the upper incisors out, you're kind of freeing up the mandible. You're kind of
True.
untrapping it.
Yeah. McNamara's got a study on that. He calls it the foot in the shoe phenomenon. Yeah.
Okay.
That's
So
one theory.
you're able to get more expansion with using the braces and wires to flare the upper teeth out more than just using a rapid palatal expander without brackets and wires.
More arch perimeter, not
Arch
necessarily more
perimeter.
expansion. Yeah. Because you're
Okay.
getting the benefit of the arch perimeter. The arch perimeter is going to come from the transverse, the width expansion, and now the incisor advancement. And that's how you're going to get more room. So a lot of times, if you look at expansion cases, and I've thousands of them with turnkey expanders, the traditional approach, they have these narrow sort of V-shaped anterior, the arch is still narrow and V-shaped in an anterior posterior perspective. So, and the palate can still be somewhat high and vaulted. And you've probably seen these patients in your practice and what you do, where they've gone through expansion, but the palate's still high and vaulted, especially anteriorly. They're still narrow in the right, and they're still narrow.
I literally just had a case yesterday where we're emailing with an orthodontist who's doing a consultation, who's an Airway orthodontist, and this child did have RPE. He's had, rapid palate expansion, but he still looks narrow.
Yeah.
A lot of the teeth are really compensated.
Yep.
He didn't have expansion on the lower. So he's still in crossbite, and it's more of a V-shaped expansion where the anterior portion is not nicely rounded horseshoe shape.
There you go.
You're like, how does that happen? Okay.
Yeah.
Keep explaining.
So if you look at the way I do it with braces and wires, which I evolved to in like 6 years into practice ish, 6, 7 years in, when I started trying to get better results, again, being critical of my own work, I still wasn't really like super Airway aware at this point. I was just realizing like, I didn't like the way this looked. I'm doing this expansion and it was relapsing more. It wasn't as stable. And it was almost too wide in the posterior sometimes because I was trying to get more space anteriorly. So like they're like blown out in the back, and right. And they're narrow in the front.
A picture of,
Yeah. And the faces are starting to get like distortion of the face, which Prophet actually says in Contemporary Orthodontics, kind of a sort of a biblical text from our educational standpoint in pediatric dentistry and ortho, that you should not expand rapidly on patients under the age of 10. He says it's contraindicated and can even be dangerous because it can cause deformation of the face. So we do it all the time. I did it. I literally thousands of times where I was turning this expander once or twice a day on a 6 or 7 or 8 year old kid on the upper, having the parents turn it. And each turn is delivering essentially, I mean, it was Isaacson had a study in the 60s, I think it was, that we talked about. I mean, it's like 3 to 10 pounds of force each turn. So you're delivering a lot of force. And from a biology standpoint, Melson had a great study in 1975 that talked about the anatomy of the mid-palatal suture. And under the age of 10, Think of it like an open highway through, this flat part of the center of the country, right? It's wide open. And as you get from 10, that she called that the infantile stage. The juvenile stage is 10 to 13. And that's when you start to get some more of a tortuous path, and you're getting some little bony spicules starting to interdigitate. And then from 14 on, you have the adolescent phase, which is where it's really torturous, and you're getting more integration of those two sides of the suture. So, and the interdigitation becomes much more profound. So when you are less than 10 and you have this wide open suture, you don't need pounds of force. In fact, I found, and the studies bear this out, you're causing a lot of inflammation. You're causing a lot of repair. There has to be a lot of repair. It's why after you expand, you got to leave the expander in there for a while, because you got to backfill in all this bone. So there are actually a lot of studies out there that talk about the benefits of a slow approach as to this expansion, which is what the braces and wires do. And I get the question all the time. People say, I just had this conversation with residents yesterday. People say to me, well, Mike, but you're not getting a radiolucency in the middle of the palate. If you take an image, then you can't be getting sutural expansion. It's all dental tipping. And that's false, because you're getting slow, gradual remodeling. Martina has a study on this in 2012. I mean, there's tons of studies out there that show that slow expansion. And Ricketts in the 70s was the first one to really figure this out, that you can apply a light force, 400-ish grams, which is about a pound, a little less than a pound. And you can apply that consistently versus an intermittent heavy force, which is what the turning of a Hyrax key does. And you can get more physiologic remodeling of the mid-palatal suture. And that's one huge benefit I found of archwire expansion, is you get this nice development. The other is the tongue isn't blocked. So one thing I struggled with, which is your wheelhouse, is here I am. I've got this kid who has no room for their tongue. They maybe have a speech issue. They've got, maybe very little control of their tongue, low tone. And I'm throwing an upper and a lower expander on this kid and expecting them to be able to talk, eat. And I had so many parents who were, they would call for either after hours or call my team during hours. And, it's torturous. And these kids this is torture devices. And my kids can't deal with this. And they're already, struggling to talk and speech, and we can't even understand them. Their teachers can't understand them in school. So these are some things that motivated me to try to find a different way. And then the last part of that is where we started on that anterior middle thirds. Well, with braces and wires, I can put the size and shape wire in that I want to use. So I can put a wire that's broader in the anterior middle thirds and use that to use the baby teeth as my anchors to develop the bone. And they're going to develop the dental alveolar bone. And they're also going to help facilitate additional sutural orthopedic expansion on these patients. So the net result is it's more comfortable. It's more physiologic force. You don't get that over expansion look. You're not fighting for space for your canines. Your canines almost always have room when you do this, literally, because of the dynamics of it when you do it the way I teach. And you get that nice proclination of those incisors. So you decouple, which allows the lower jaw to grow more. There's so many advantages. But it's just, we're taught you don't put braces on baby teeth. So even people who do a lot of phase one, who may be more airway aware, that's one huge hurdle. And you're asking them to take another hurdle and now be like, now put full braces on these younger kids.
So just to make sure I understand, when you're doing your arch wire expansion, is that what you call it?
Yeah. Yep. Exactly.
You're not using a rapid palatal expander at the same time. You're not using that at all. It's just expansion through braces and wires. Wow. Okay. Now I get that. And I can only imagine with orofacial myofunctional therapy, that is like a perfect blend if you recommend that for your patients and they do follow through with that recommendation, because that tongue can be like that palatal expander to help hold that arch with the lips.
You got it.
Act like the braces for the teeth to help maintain all that. So that would be a beautiful combination. If hopefully patients get that recommendation. So,
and on that, Nicole, I didn't know that was going to happen, because when I'm starting, and this is going back almost 15 years ago, I'm kind of like not knowing what I'm really even doing, other than I'm just trying to find better ways to develop these arches and get space for the teeth and help the patients grow and normalize the anatomy. And then I started looking at these cases and I'm thinking, even when I had just the lightest of wires in, especially on patients with cleft craniofacial anomalies, the arches are starting to expand in like 8 weeks. They'd come back in for their next adjustment. And there's no way that an 014 nickel titanium wire should get that type of transverse movement. studies show you just that probably isn't enough force. Well, what is it doing? It's initially probably just tipping the teeth, but now the tongue starts to have more space to position itself more anteriorly and superiorly. And the tongue can now shape the palate and be nature's expander and develop the arches. Whereas when you have these big, bulky expanders, one sitting right behind the lower incisors and the other right up in the roof of the mouth, where's the tongue going? So you're again, I'm not saying it's wrong to do it that way. It's
indicated for correct
but you're
tongue
kind of
posture.
right. You're basically making your life a little harder. Yeah.
And usually we don't even do myofunctional therapy when there's a rapid palatal expander and we wait
Right.
And say, come back when that's removed. We don't usually start a program when somebody is about to get their expander on.
Right.
And in a lot of cases, I think the tongue probably won't automatically go up. Lips don't automatically close. Muscles need to be trained and also a good evaluation because there's other factors in many cases like nasal obstruction,
Sure.
allergies and large adenoids, turbinates, tonsils, tongue tie. There might be other reasons why that initial soft tissue dysfunction was there to begin with.
Of course.
Triggering that malocclusion. So it's really that team approach of the orthodontist initiating techniques like what you're talking about, the myofunctional therapist, because usually we're the ones evaluating those components and saying, go to the ENT, go to the allergy doctor, and also those other airway specialists, ENT, allergy doctors, like all of our work together is what helps really make this kind of gold. What makes it all
completely. And I feel like the orthodontist should really be the quarterback of this. And I feel it's our responsibility to detect this, we have the cone beam capability. We should take these. I mean, it's what I did. And you detect this, you detect the nasal passageway issues and potential allergies, get them to the allergist. You detect the obstruction of lymphoid tissue, get them to the ENT. You detect the oral facial musculature issues, get them to the myofunctional therapist. I mean, there's no reason for us not to quarterback this and then use
almost like a handoff, right? Like, toss me the ball. And then like with our patients as myofunctional therapists, when they come to see us, I'll tell you, I rarely have had anybody do an evaluation and not follow through with treatment because we take 1-2 hours in our evaluation to explain it all. So they get it. And they're like, wow, this makes sense. I need to follow your recommendations. And I have so many patients who I might kind of overwhelm them with things to do and referrals.
Fair, yeah.
And a lot of them do them all. I'm like, wow, you just called 10 people and, did all this. They'll follow through. But if not, we see them weekly for usually at least 2 months, once a week. We're there to follow up. I tell people when I train them, you're going to kind of nag people and that's okay because they actually appreciate it because people are busy with, their kids doing this and school and work and, life. People in this healthcare realm don't mind if you're bothering them and because you're supporting them and you're following up. So you're going to ask them every week, did you call the ENT? What is the orthodontist? You're just going to do that every week. You write in your notes and you just keep asking that same question. How's your breathing? How's your congestion? Did you tip the head of your bed up? Are you making sure you're not eating 2 hours before bed? I mean, you're just going to repeat, but people appreciate it. Usually no one said to me, stop asking. And I know to stop asking when it's been done. And I check that.
Right. Check that box.
So we have 5 minutes and I know we're going to do part 2. Are you okay? Part 2?
Absolutely.
A different time.
Yep,
okay.
For sure.
So for part 2, I know what I want to talk about is the AAO white paper statement, the 2017 ADA position statement. I want to talk a little bit about your thoughts on adult expansion. That's going to be part 2. Also, just some other things about why maybe headgears are still being used and just different techniques, how maybe traditional orthodontists might do certain techniques versus the airway techniques. I have 2 really quick questions though, before we wrap up.
Yeah, sure.
When we see braces on a patient, I assume the majority are not doing the arch wire expansion. Is it logical to think that when a child or even an adult has braces, it's usually retractive? Or not? I can't conclude that. Like,
a lot of it depends on that person's technique and philosophy. So, guys that he was on my show, Tom Pitts, who's just a pioneer in this arena. Tom's been doing arch wire expansion type of approaches since the 70s. I mean, he learned from guys that I was mentioning like Ricketts, and I mean, he just genius. Damon, a lot of people heard the Damon philosophy, and that's more of an expansive approach. So You could, braces aren't braces, and just like clear liners aren't clear liners, some people really push the envelope with clear liners and expanding. I did.
Yeah.
And you can use that even sometimes in a phase 1 to help develop those arches and expand the patient. So a lot of it just depends on that practitioner's philosophy. And I
Probably
guess
more rare that like
well, if there's someone who's going to extract teeth, if there's someone who doesn't want to develop those arches and wants to extract teeth, then yeah, then that person is going to be more of a retractive type of approach, because they're treating the symptom. They're going to pull the teeth. They're going to put braces on to try to close the spaces. And that's the other thing. And I can go a few minutes past too, if to go over that. If you take a patient who is crowded, each tooth in each quadrant, right, each premolar is about 7.5 millimeters. So if you pull 2 in each arch, you're getting 15 millimeters on average of space. That is 1.5 centimeters of space. How can they not be retractive? You could be one of the most technically sound orthodontists out there, and we call it anchorage. Just look at the tug of war. You're telling me you're going to bring all those posterior big strong teeth with those multi-roots forward, and those little incisors are going to do all the work. And you could say, well, I'm putting mini anchors and TADs and all that in. But a lot of the people who are doing this are not for every case. They're closing space, and you're going to get some posterior forward and some anterior backward, and that becomes your retractive. So it's not that the extractions are causing the airway problem. It's that the airway problem existed due to the narrow deficient arch width, and the teeth being crowded was the symptom. And instead of normalizing the anatomy by developing and expanding the arches, you decided to treat the symptom by removing tooth mass. But if they had 8 millimeters of crowding, which we call severe, you basically still have twice that. You have that amount to close of space, even in a patient who has severe crowding. Right. So that's where that retraction comes from, is trying to close up that space when you've misdiagnosed the actual etiology of the problem.
Perfect answer. And could you also think of it as, if the teeth are so crowded that you need to extract teeth, you could have, on the contrary, grown 15 millimeters of space if you expanded.
Well, completely, but you only needed 8. Every now and again, you'll get a patient who has 10, maybe 12. Maybe, like big maybe, but it's rare to see that much crowding. Usually you're in that, 8 to 10 is like pretty severe to see. A lot of times you're dealing with 5 to 7. And Nicole, people are extracting teeth for 5 to 7 all the time. So, now you're left with a centimeter of space to try to close up, and you have no choice but to be constrictive, because what is the converse of expansion? Like expanding to make space and increase perimeter. The converse is constricting to decrease space and decrease perimeter. So it's not that complicated to think about why it happens. The key is if you wait and don't try to normalize anatomy young, and you just wait till these patients are older and those teeth have all erupted, at that point, it can be almost, I don't want to say impossible, but it can be very challenging to try to solve that non-extraction. You still can, and I push that envelope big time in my practice, but there comes a time when all those teeth are in and you haven't had the ability to develop the bone ahead of time, where, what are you going to do? Where are you going to put the teeth? You can only expand so much. So logistically, it can become a challenge.
It's a missed opportunity.
Exactly.
And that makes sense. Yeah. The extractions aren't causing the apnea or the airway or the sleep problem. There was a problem there to begin with, and it was not addressed properly, and maybe could have been resolved had one done a different technique.
Perfectly stated. Yep.
Really great. Okay. I want to just sum things up. And of course, I always write notes, and then I'm like, why did I make a mess? I have notes like all over the place.
I do the same
my
thing
summary is going to be random words all over the place. But really, what we have to talk about is not everything's airway. That's really important to know. If you have a hammer, not everything's a nail, right? So not all of these orthodontic patients are going to have airway issues, although there's a high comorbidity and correlation between malocclusion and airway problems.
Correct.
But we didn't talk about this, but we also need to be aware there's other non-anatomical components for sleep problems, such as ferritin issues, narcolepsy, circadian rhythm
issues. Yep.
tons of other issues that we also, once we go down the airway rabbit hole, it's kind of like a sleep rabbit hole, a breathing rabbit hole. We also need to be aware that not everything is sleep and airway, and sleep in terms of anatomical airway. There's other factors as well. We want to look at our patients from a comprehensive patient wellness approach and not be reactive, but really important to be proactive and looking at that phase 1 treatment to think of airway and developing the arches and asking the correct questions, because a huge percent of those cases of young children with malocclusion probably are having some airway related component, or will, if we don't address early. We don't want to let our treatment follow the reimbursement. And in the United States, a lot of reimbursement will be just a one-time thing for orthodontic treatment. You don't want to use it all up in the beginning, is what people might say. Or there might not be reimbursement for phase 1, but we really need to think outside the box, because insurance is not always on our side. They're on their side. Insurance is on insurance's side, right? It's important to be curious, like you were when you got started in this journey. These concepts of airway are not new concepts, as you stated, studies from such a long time ago. And we need to really not be dogmatic in our approach, but think outside the box to ask the question, why? Why are we seeing these problems? Because what we're seeing oftentimes is a symptom of something deeper, right? A more larger problem. And we want to, not just be tooth driven, or there's a difference between tooth driven focus and thinking of the whole body. And, just think, let's normalize the anatomy. Why not? You don't have anything.
And when you normalize the anatomy, the teeth almost always look good. I mean, it's hard to find a case where you've normalized the anatomy and put everything in a decent spot, and the smile doesn't look aesthetic. Conversely, if you don't normalize the anatomy, you can straighten the teeth as beautifully as you want. And you could, the old school of putting those models on a table and lining them up to make sure everything looks right. You look at the patient's smile and it leaves a lot to be desired. The cases I was telling you about, I showed in that webinar, look at just their teeth. When I showed just their teeth, their occlusion looks beautiful. Their teeth look beautiful. You look at their smile on the face that it fits in, not so much.
Yeah. Yep. Look at the whole face. Look at the chin, the neck, like the whole, around the eyes. And also with your arch wire expansion technique, that's a really interesting approach, because you can get really good expansion without using a turnkey expander. But by proclining the incisors, you're getting more arch perimeter, and that helps with more tongue space and doesn't block the tongue. So that's a really interesting technique that
sorry to interrupt you, but I should clarify, if that's only in younger patients that can't, you're not going to go in at 14 and get that type of effect. It's best done in the patients younger than 9, ideally. Working on a study right now at Nova. We're trying to look at that a little, quantify that a little more, but you want to get them in that younger age for the arch wire type expansion.
That makes perfect sense. And how you describe the suture under 10 is that infantile phase where it's like a wide open highway, I think you said. And then like 10 to 13, the juvenile stage where they're starting to interdigitate. And then 14 and beyond, the adolescent phase where things are more locked in. And slower expansion techniques sound like they're better at that younger phase, because we allow that physiologic remodeling of the suture, kind of working with the body. And we talked at the end about extractions aren't the reason someone has an airway problem. And we could just end with that. It's not the initial reason. There was something underlying that with deficient growth, and that just did not help. And probably, in my opinion, made it worse. But it wasn't. This was so great, and I'm so excited for part 2. We'll do that some other time.
Happy to. I love speaking with you, and really enjoy it so much. You got a great show, and thank you for all you're contributing to this profession and your quest to push this, because it really, really does help. It raises awareness on such a broad level, and as we said in the beginning, this has to be it's a clan, it's a group that's got to work together in this journey. So.
Same to you with the Doc podcast that you do, spreading this message, especially being an orthodontist. Spreading the message to orthodontists is so important, as well as the general public. So thank you so much. And we'll be back a different time for part 2. Thank you, Dr. Mike DeLuke. Really appreciate it.
Sounds great. Thanks so much, Nicole. Appreciate it. Take care.
Thank you so much for joining this episode of Airway Answers. I'm hoping some of your